would like to present this topic, psychosocial rehabilitation in Ponoka, Canada. Ponoka is a small town located in Alberta province in Canada. I worked in this hospital for about 15 years. This hospital was built more than 100 years ago. In 1907, Act was passed to put the mentally ill patients in the asylums. And this hospital was built at that time in Ponoka town, which is about 100 kilometers south of Edmonton, the capital of Alberta, and about 200 kilometers north of Calgary, which is biggest city in Alberta. This was at that time a state-of-the-art hospital with everything having by itself. This was the picture taken in 1910, and as you see that it has its own power station, it has its own heating and water system and everything, it has its own. And it was fireproof because it was out of the town, about 3 kilometers out of the town. In 2003, this new building was built by $100 million, and the old building was demolished except the one which was the main building. It has kept as heritage. And this hospital has 325 beds, 152 adult inpatient, 125 seniors or geriatric psychiatry beds, and 48 beds for brain injury rehabilitation. This hospital is a state-of-the-art hospital again, being a new hospital. This is gym, swimming pool for the patients, and the woodwork program, pottery. So coming to the prevalence of mental illness in Canada, 1 in 3 Canadians, about 9 million people, they meet the criteria of at least one of the 6 selected mental illnesses or substance use. About 3.5 million Canadians, or 12.56, met the criteria of mood disorder during their lifetime. And 2.4 million reported symptoms consisted with generalized anxiety disorder during their lifetime. 21% met the criteria of the substance use disorder. So looking on this prevalence and the admission rate, the hospital decided to have a psychosocial rehabilitation program. It's called PSR. The program is client-centered. It supports individuals with mental illness to engage in their recovery. And recovery by itself is a process in which individuals redefine themselves by acknowledging them that illness is only one aspect of their identity. Common notion is psychotic. Unfortunately, even in Western society, the word psychotic is used for them, and that is by itself a stigma. So concept of this psychosocial rehabilitation is that it is one part of their illness, it is not their identity. And the key elements: individualization, hope, client-directed, focus on skills, strengths and abilities. It was environmentally specific, environmental support, partnership approach, and not only at that time approach support, but it's ongoing support. Skills and supports in balance. And what is individualization? Means services must be custom tailored to the individual, flexible, and driven by the individual choice. Hope means belief in potential to the change and grow even most severely disabled individuals. Even those people who are chronic schizophrenic, yes, they can work, they can do something, they can live by themselves. So there is always a hope. Client directed, people have a right and responsibility for self-determination. That yes, they have also right to say that what is good for them, what is not good for them. Focus on the skill. Core of rehabilitation is increased competencies through skill acquisition. And strengths and abilities means emphasis on current strengths and abilities, not on the symptoms. What person is potential for, that is most important thing, not the symptoms. Environmentally specific strengths and abilities must be assessed in relation to a specific environment. Skills must be taught in relation to the environment in which they will be used. Environmental supports, modifying the environment and building external supports are equally as important as skill teaching is. So teaching is one aspect, but providing support so that the idea is that they should be living independently and they should be on their own as much as they can. Partnership approach, the creation of an intimate environment with no professional authoritative barriers is the essential. Ongoing support program should not be limited at that time. It should be ongoing support. Skills and supports in balance, a person does better when improving, learning 1 to 2 skills at a time. Not everything should be taught at one time, but 1 to 2 skills, and it should be ongoing process. The goal of the PSR program is to assure that the individual with a mental illness process skills needed to live, learn, and work in an environment in the community. Focuses on teaching functional and coping skills that are necessary. How the referral was made during these different years. 169 in 16-17. As you see, that number is increasing from 2010 to 2016 and 17. The average wait time between referral was about 31 days. Where from these patients were coming? From other hospitals, from within the hospital, and the community. So majority was from the community or from the within the hospital itself. And from outside hospital, there were few referrals. Discharge and the length of stay. So length of stay was about 80 to 100 days from different time. From 2010, it was, the maximum stay was 130 days in 2012 and 13. And minimum was in 2016 and 17, that was 82. And the number of discharges varies from 47 to 86 during these years. So where these people were placed after discharge? Most people were independently discharged. They were living by themselves. Then number goes semi-supported, fully supported, and in the facility. So most of them, they were independently discharged in the community and they were living by themselves. What was the outcome of this program? All clients who engage in the program complete pre and post program measures for the purpose of program evaluation and further developments. Quality of life improvement is the measure of life satisfaction focused on 16 areas of life such as love, work, and health. So 0 to 36 was very low and 58 to 77 was high. So if you see that the admission at that time, if you look on 2016 and 17, at that time the score was 32 and the discharge score was 46. So that by itself shows that it was really very good improvement. Except 1 year, 2015 and 17, the number was low, but mostly it was very high. Adult dispositional hope scale. The greater individual score, on this measure was, the higher their hope was. So again, with the discharge, the number was much higher than the admission time. Empowerment scale. The empowerment scale is designed to measure the personal construct of the empowerment. Higher average score suggests greater empowerment. The highest possible average on this measure is 4, and the lowest possible score is 1. So if you see that number in 2011, mean was 2.69, and at the discharge it was 2.9. And the 2014, it was 2.93. The mean was 2.93. Self-esteem. The self-esteem was measured as well to see that how person's self-esteem has been working. Higher the respondent's self-esteem, lower the score and higher was the respondent's self-esteem. Average was less than 20 and severe was more than 27. So at admission in 2011 it was 25 and at discharge it was 21. So score was going less every year. Functional capacity, that how person would be doing functionally. Pre-basic was 0 to 5 and advanced was 21 to 25. Again, mean was 24.42 in 2017. Leisure satisfaction, that how much they are enjoying their life and the leisure. It's a self-assessment tool which assesses the degree to which individual perceives his needs are being satisfied through leisure activities. Occupational therapy or functional therapy was working with this, and the lowest score was less than 2 and highest was more than 4. Same results, that it was much more higher at the discharge time. Pre and post PSR program hospital admissions, 2 years time, that how many people they were readmitted. And with the diagnosis, in 2011, the mood disorder, there were pre-admission. In this program, the admission rate was 26 and post-admission it was 11. It was minus 57%. With the personality disorder, the readmission was quite high. So this program unfortunately was not good for the personality disorder. And when we are talking of personality disorder, we are talking more of the borderline personality. Schizophrenia, pre-ed was 21 and after it was 13 in the 2011, and in 2017, 16, 17 it was 88 and 65. Substance abuse was 54 and 47. Neurotic disorders 45 to 24. Much less in neurotic disorder and very good in schizophrenia. So evidence suggests that there is a significant decrease in post-PSR program admissions for clients living with mental illnesses, especially those with schizophrenia, schizotypal delusional disorder. So personality disorder, it was 55% decrease, and there was an increase in the substance use disorder. 3-year combined data was, overall it was minus 37% decrease in the hospital readmission. So this was PSR program, and it shows that mainly it worked very good for the schizophrenic disorders, but not very good for the drug addiction program. It was not good for them. For the substance use, it was not good. Thank you very much.